Hey everyone, welcome to the human side of hospitals. I'm so glad you are here. And now on this channel, we don't just talk about medicine, we listen to real people, to patients, to doctors, nurses, caregivers, anyone who has an unforgettable hospital experience. The hospitals can be places of healing, hope, sometimes even heartbreak, and every story has something to teach us. That is why I'm starting this, just to give people a space to share, to be heard, and to remind us that behind every hospital wall are human beings with stories worth telling. Now, here's where you come in. So, if you've ever been a patient, if you've worked in a hospital, or if you've supported a loved one through their hospital journey, I would love to hear from you. And you can send me a short video, audio, just write your story down. Or if you would like to sit and chat with me, you can join me live on Zoom. And all you have to do is just fill the form in the description below, or you can send me an email. And it doesn't matter where you are from, who you are, or whatsoever. You are welcome wherever part of the world you come from. And before we dive in, don't forget to hit the subscribe button and turn the notification bell. Basically, not to miss these incredible voices from around the world. And a quick disclaimer before we start: these stories, their personal stories, shared with full consent, and we are here just to inspire, educate, and raise awareness. One thing is those who want to remain anonymous online, well, for the sake of confidentiality and privacy, altered some of their voices into AI voices. And note that even the advice shared in these videos or in these experiences, they are not a substitute for medical advice. Always remember this. And if you have health concerns, always speak to a qualified healthcare professional. All right, let's dive into today's story.
I'm Nathan Caldwell, Senior Operating Room Nurse at Riverside Medical Center in Columbus, Ohio. Or at least, I held that position until I submitted my resignation 3 weeks ago, after 11 years of what I thought was distinguished service in one of the state's busiest trauma centers. My credentials speak for themselves. Bachelor of Science in Nursing from Ohio State University, Certified Perioperative Registered Nurse through AORN, Advanced Cardiac Life Support Certified, and specialized training in cardiovascular and neurosurgical procedures. I've assisted in over 4,000 surgeries, from routine appendectomies to complex 12-hour cardiac transplants. I've seen gunshot wounds that defied anatomy textbooks, cancers that spread in patterns that made seasoned oncologists scratch their heads, and trauma cases that pushed the boundaries of what the human body could survive. I thought I'd witnessed every medical anomaly possible in an operating theater. Burns that covered 90% of a patient's body, yet left them conscious and talking. A construction worker who walked into our ER with a steel rod completely through his skull, asking for directions to the bathroom. A woman who delivered twins after being declared clinically dead for 8 minutes. But what I'm about to share is the single case that shattered everything I believed about medicine, human physiology, and the very nature of life and death. It's the case that forced me to question not just my career, but my understanding of reality itself, and ultimately drove me to abandon the profession I loved. Riverside Medical Center sits on a sprawling 40-acre campus on the east side of Columbus, a level 1 trauma center serving central Ohio's population of nearly 2 million. The surgical wing houses 12 operating rooms, each equipped with the latest technology, Da Vinci robotic surgical systems, intraoperative MRI capabilities, and cardiac bypass machines that can keep a patient alive for hours without a beating heart. I primarily work OR7, the cardiovascular suite, where we handled the most complex cases that came through our doors. The morning of October 15, 2024, started like any other Tuesday. I arrived at 5:30 a.m. for the 6 o'clock shift change, reviewed the surgical schedule with night nurse Angela Morrison, and began prepping for our first case, a routine coronary artery bypass graft scheduled for 7:30. The patient was Robert Henley, a 56-year-old insurance adjuster from nearby Westerville with severe 3-vessel coronary disease. Dr. Elizabeth Yamamoto, our lead cardiac surgeon, had performed this exact procedure hundreds of times. The surgical team was equally experienced: Dr. James Kowalski on anesthesia, surgical tech Hannah Rodriguez, and perfusionist Alan Chen managing the heart-lung bypass machine. We'd worked together for years, a well-oiled machine capable of handling anything the human cardiovascular system could throw at us. At precisely 7:28 a.m., Mr. Henley was wheeled into OR 7. Standard preoperative vitals were textbook normal: blood pressure 128/82, heart rate 72 beats per minute, oxygen saturation 98% on room air, temperature 98.4 degrees Fahrenheit. Dr. Kowalski administered the anesthetic cocktail: propofol, fentanyl, and rocuronium, following our standard protocol. Within minutes, Mr. Henley was unconscious and intubated, connected to our Dreger Apollo anesthesia machine. The surgery began without incident. Dr. Yamamoto made the median sternotomy incision with her usual precision, using the Stryker bone saw to cut through the sternum. Hannah and I retracted the chest walls with the standard Finocchietto retractor, exposing the heart and surrounding structures. Everything appeared exactly as expected from the preoperative cardiac catheterization films. Severe stenosis in the left anterior descending artery, right coronary artery, and circumflex artery. At 8:45 a.m., we initiated cardiopulmonary bypass. Alan connected the venous cannulas to drain blood from Mr. Henley's right atrium, while the arterial cannula returned oxygenated blood to his ascending aorta. The heart-lung machine took over circulation, allowing Dr. Yamamoto to stop the heart with cardioplegia solution for the delicate graft work. This is where everything I knew about cardiac surgery, human physiology, and medical science itself began to unravel. The moment Alan clamped the aorta and delivered the cardioplegia, Mr. Henley's heart should have stopped beating within 30 seconds. That's basic cardiac surgery. You flood the coronary arteries with a high potassium solution that arrests all electrical activity. The heart becomes completely still, a motionless organ that allows surgeons to work with millimeter precision. But Mr. Henley's heart kept beating. Not just kept beating, it maintained a steady, strong rhythm of exactly 72 beats per minute, the same rate it had displayed before anesthesia. Dr. Yamamoto exchanged glances with Alan, who immediately checked his perfusion lines. Everything was connected properly. The cardioplegia solution was flowing into the coronary circulation at the correct pressure and temperature. "Let's try another dose," Dr. Yamamoto said, her voice maintaining professional calm despite the furrow in her brow. Alan delivered a second bolus of cardioplegia, double the normal concentration. In 11 years of cardiac surgery, I'd never seen a heart receive that much arresting solution and continue functioning. It should have been physiologically impossible. Mr. Henley's heart continued its steady 72-beat rhythm. "Nathan, can you verify the cardioplegia composition?" Dr. Yamamoto asked. I checked the solution bag hanging from our IV pole. 4:1 blood to crystalloid ratio, potassium concentration of 25 milliequivalents per liter, magnesium 16 milliequivalents per liter, temperature 4 degrees Celsius. Everything was precisely according to our cardiac surgery protocol. Dr. Kowalski spoke up from the anesthesia station. "All monitors show complete neuromuscular blockade. He's getting continuous propofol and fentanyl. There's no way he has any cardiac autonomic function right now." But the heart kept beating. What made it even more disturbing was the quality of the contractions. This wasn't fibrillation or any kind of arrhythmia. The heart was beating with perfect synchronized contractions. Atria filling, ventricles contracting, valves opening and closing in textbook sequence. On the monitors, his ECG showed normal sinus rhythm despite being on complete cardiopulmonary bypass, with enough cardiac arresting medication to stop an elephant's heart. Dr. Yamamoto made a decision that violated everything we'd been trained to do. She began the bypass grafts on a beating heart. Performing coronary artery surgery on a beating heart is technically possible. It's called off-pump surgery, but it requires specialized equipment and techniques we weren't using. The heart stabilizer devices, the positioning systems, the modified suturing approaches. We had none of that set up because this was supposed to be a standard on-pump procedure with cardiac arrest. Yet Dr. Yamamoto, with surgical skills I can only describe as otherworldly, began suturing a saphenous vein graft to the left anterior descending artery while the heart continued its steady contractions. Her hands moved with impossible steadiness, placing stitches with surgical precision I'd never witnessed. Each suture was perfectly placed despite the constant motion of the beating heart. "Nathan, I need better visualization," she said. I adjusted the surgical lights and retractors, watching in fascination as she completed the LAD graft in half the time it normally took on an arrested heart. The anastomosis was flawless, better than flawless. Under the surgical microscope, every stitch was identical, spaced exactly 2 millimeters apart with perfect tension and depth. She completed all 3 grafts in 90 minutes on a beating heart, without specialized equipment, with surgical precision that defied human capability. But that wasn't the most disturbing part. Throughout the entire procedure, our monitoring equipment recorded impossible data. The heart-lung machine showed it was providing full circulatory support, yet Mr. Henley's natural heart was simultaneously maintaining perfect circulation on its own. We were essentially running 2 complete circulatory systems in parallel, which should have caused catastrophic hemodynamic instability. His blood pressure remained rock steady at 120/80. His cardiac output, measured by both the bypass machine and our Swan-Ganz catheter, showed perfect numbers from both his natural heart and our artificial circulation. The math didn't work. You can't have 2 hearts, one natural, one mechanical, pumping the same blood volume without creating dangerous pressure changes. Yet every parameter remained absolutely normal. Dr. Kowalski was monitoring cerebral oximetry, blood gases, and neurological function. "I'm seeing perfect brain perfusion from both circulation sources," he announced, his voice carrying a note of bewilderment I'd never heard from him in 15 years of anesthesia practice. When it came time to wean Mr. Henley from cardiopulmonary bypass, Dr. Yamamoto faced another impossibility. Standard protocol requires gradually reducing the bypass machine's support while allowing the patient's heart to resume full function. You slowly decrease the machine's flow rate while watching the heart's natural output increase to compensate. But Mr. Henley's heart had never stopped working. We were essentially stopping a machine that had been running in parallel with a perfectly functioning natural heart for over 2 hours. Alan gradually reduced the bypass flow, while we all watched the monitors with fascination and growing unease. As the machine's support decreased, Mr. Henley's natural cardiac output should have increased proportionally. Instead, it remained exactly the same. 72 beats per minute, perfect stroke volume, optimal cardiac output. It was as if his heart had somehow known exactly how much work the bypass machine was doing and had been automatically adjusting its own function to maintain perfect physiological balance. The level of biological feedback and control this implied was far beyond anything in medical literature. We completed the bypass separation without incident. Dr. Yamamoto closed the chest with her usual meticulous technique, though I noticed her sutures were even more precise than normal, if that was possible. Every stitch was identical, creating the wound closure that looked more like machine work than human surgery. Mr. Henley was transferred to the cardiac ICU in stable condition. His post-operative course was, like everything else about his case, impossible. Recovery from cardiac bypass surgery typically involves several days of intensive care monitoring. Patients experience pain, inflammation, fluid retention, and gradual return to normal cardiac function. There's always some degree of post-operative arrhythmias, blood pressure fluctuations, and the need for various medications to support cardiovascular function. Mr. Henley experienced none of this. 4 hours after surgery, his chest tube drainage was minimal, less than 50 milliliters of the typical 200 to 300 milliliters we'd expect. His pain scores remained at 0 despite receiving only acetaminophen. His blood pressure, heart rate, and cardiac output remained exactly the same as during surgery. 120/80, 72 beats per minute, perfect cardiac index. Dr. Jennifer Walsh, our ICU attending, called me at home that evening. "Nathan, I need you to look at something. Can you come in?" I drove back to the hospital to find Dr. Walsh staring at Mr. Henley's post-operative ECG tracings. She had printed out continuous rhythm strips from the previous 8 hours. "Look at this," she said, spreading the papers across the nursing station desk. Every single heartbeat was identical. Not similar, identical. The same exact wave morphology, the same precise intervals, the same amplitude measurements. In 8 hours of continuous monitoring, Mr. Henley's heart had produced what appeared to be thousands of photocopies of the same heartbeat. "In 30 years of cardiology, I've never seen anything like this," Dr. Walsh said. "Normal hearts have natural variation, tiny changes in timing, voltage, morphology. Even the most stable patients show microsecond differences between heartbeats. This is like watching a machine. I studied the rhythm strips. She was right. Every QRS complex, every P wave, every T wave was absolutely identical. The measurements showed variation in the thousandths of a second, far below the resolution of our monitoring equipment." "What about his lab work?" I asked. Dr. Walsh pulled up his blood chemistry results on her computer. "Everything's perfect. Not just normal, perfect. Hemoglobin exactly 14.0 grams per deciliter, hematocrit exactly 42%, white blood cell count exactly 7,000. No decimal places, no variation. Every single lab value is precisely at the textbook ideal." The following morning, I returned to OR7 for our scheduled cases, but I couldn't stop thinking about Mr. Henley. During our break, I visited the cardiac ICU to check on his progress. He was sitting up in bed, completely alert and comfortable. No supplemental oxygen, no intravenous medications, no signs of surgical stress. His chest incision looked like it had been healing for weeks, not hours. The skin edges were perfectly aligned with minimal inflammation. "Good morning, Mr. Henley," I said. "How are you feeling?" "Perfect," he replied with a slight smile. "Never felt better in my life." I checked his chart. 24 hours of post-operative, he was scheduled for discharge. In 11 years of cardiac nursing, I'd never seen a bypass patient ready for discharge in less than 3 days, usually longer. Dr. Yamamoto appeared for her morning rounds. "Nathan, Mr. Henley's case has me puzzled," she said quietly. "I've been reviewing the operative video, and I'm seeing things that don't make sense. Our OR7 records all procedures for educational and legal purposes. Dr. Yamamoto had spent the previous evening analyzing the footage of Mr. Henley's surgery. "Watch this," she said, pulling up the video on her tablet. The footage showed her performing the coronary anastomoses with the impossible precision I'd witnessed in person. But reviewing it in slow motion revealed something even more disturbing. Her hand movements were too fluid, too perfect. There were no micro corrections, no slight tremors, No natural human variations in her surgical technique. I don't remember performing surgery like this, she said, her voice troubled. This looks like my hands, my technique, but somehow enhanced beyond my normal capabilities. She was right. Watching the video was like seeing a surgeon operating at superhuman levels. Every movement was economical, precise, and performed with mechanical perfection. There's something else, Dr. Yamamoto continued. I've reviewed Mr. Henley's preoperative cardiac catheterization films. The coronary blockages we bypassed yesterday, they're not visible in these images anymore. She showed me the cardiac catheterization films taken just 3 days before surgery. The images clearly showed the severe 3-vessel coronary disease that had indicated the need for surgery. But examining them now, the coronary arteries appeared completely normal, with no signs of atherosclerotic disease. These are the same films, she insisted. Same patient ID, same date, same cardiac catheterization suite. But the pathology we operated on has somehow disappeared from the imaging. I spent the next 2 days investigating Mr. Henley's case, reviewing every piece of documentation, every test result, every monitor recording. The more I discovered, the more impossible everything became. The cardioplegia solution we'd used had been tested by our pharmacy. The potassium concentration was exactly as ordered, more than enough to arrest any human heart. But somehow, it had no effect on Mr. Henley's cardiac function. The bypass machine's flow records showed we'd provided full circulatory support for over 2 hours. But Mr. Henley's heart had simultaneously maintained perfect circulation, creating a parallel circulatory system that should have been physiologically catastrophic. The surgical video showed Dr. Yamamoto performing with capabilities that exceeded normal human dexterity and precision. Yet she had no memory of the enhanced surgical skills she demonstrated. The post-operative monitoring revealed heartbeat patterns of mechanical regularity that no biological system should produce. Every cardiac cycle was identical to microsecond precision. Mr. Henley was discharged on post-operative day 2 with perfect incision healing, normal cardiac function, and no need for follow-up care. His insurance company initially questioned the early discharge until they reviewed his test results and realized he was in better cardiovascular health than most people half his age. 3 weeks later, we had another case that defied medical explanation. Linda Kowalski, a 43-year-old accountant from Grove City, required emergency surgery for a ruptured abdominal aortic aneurysm. She arrived in hemorrhagic shock with blood pressure barely detectable and massive internal bleeding. Dr. Miguel Santos, our chief vascular surgeon, estimated she had minutes to live without immediate surgical intervention. The surgery should have been straightforward, but technically challenging. Replace the ruptured portion of her abdominal aorta with a synthetic graft. But, like Mr. Henley's case, everything about Ms. Kowalski's surgery violated the rules of medicine and human physiology. Despite losing an estimated 4 liters of blood, nearly her entire blood volume, she remained conscious and responsive throughout the preoperative period. Her blood pressure, while low, remained stable at 90/60 without any vasopressor medications. Patients with ruptured aortic aneurysms typically require massive blood transfusions and aggressive hemodynamic support just to survive long enough for surgery. Ms. Kowalski required neither. During the procedure, Dr. Santos encountered the same impossible precision that had affected Dr. Yamamoto. His surgical technique, normally excellent, became supernaturally perfect. He replaced a complex portion of her aorta with vascular anastomoses that looked like textbook illustrations. The synthetic graft integration was immediate and complete. Normally, vascular grafts require time for tissue incorporation and endothelialization. Ms. Kowalski's graft appeared to integrate with her native vessels immediately, showing blood flow patterns identical to natural aortic tissue. Her recovery was equally impossible. No post-operative complications, no signs of the massive hemorrhagic shock she'd experienced, and discharge planning within 48 hours. Her post-operative CT angiogram showed the graft functioning perfectly, with blood flow characteristics identical to a native aorta. But the most disturbing discovery came when I reviewed her preoperative imaging. The CT scan that had clearly shown a ruptured abdominal aortic aneurysm now showed completely normal vascular anatomy. Like Mr. Henley's cardiac catheterization films, the pathology we'd surgically corrected had somehow vanished from the original imaging. 2 impossible cases in 3 weeks. Both patients experiencing medical phenomena that violated fundamental principles of human physiology. Both surgeons demonstrating enhanced capabilities beyond normal human limits. Both showing identical patterns of perfect recovery and mysteriously altered preoperative imaging. I began investigating our patient database, looking for similar cases. What I found shattered what remained of my confidence in everything I thought I understood about medicine. Over the previous 2 years, Riverside Medical Center had treated 17 patients who displayed similar impossible characteristics. Cardiac surgeries on hearts that wouldn't stop beating. Orthopedic procedures where bones healed during the operation. Neurosurgeries where brain tissue regenerated in real time. Cancer resections where tumors disappeared between imaging and surgery. Every case involved patients who should have had serious medical conditions but experienced perfect outcomes with impossible recovery patterns. Every surgeon reported enhanced technical abilities during these procedures. Every patient was discharged in better health than they'd had in years. And in every case, the preoperative imaging that had indicated the need for surgery showed normal anatomy when reviewed afterward. I brought my findings to Dr. Amanda Foster, our chief of surgery. She listened to my presentation with growing concern, reviewing the documented cases and medical records I'd compiled. "Nathan, what you're describing is medically impossible," she said, "but the documentation is undeniable. These patients, these outcomes, these surgical videos, they're all real." She agreed to convene a medical review board to investigate the cases. For 2 weeks, a panel of our most senior physicians examined every aspect of the 17 cases. They interviewed the surgical teams, reviewed all documentation, consulted with external medical experts, and even brought in investigators from the state medical board. Their conclusion was as disturbing as it was definitive. The cases were real, the outcomes were documented, and every aspect of the medical care provided was beyond current scientific understanding. Dr. Foster called me into her office after the review board completed their investigation. "Nathan, we need to discuss your future here at Riverside." I assumed I was being disciplined for bringing attention to cases that challenged the hospital's reputation. Instead, she offered me a promotion to Director of Quality Assurance, with responsibility for identifying and documenting unusual cases. "We need someone with your attention to detail and investigative skills," she explained. "These cases may represent a new frontier in medical science, or they may indicate something we don't yet understand about human physiology and surgical intervention." I turned down the promotion. That night, I went home and wrote my resignation letter. After 11 years of nursing, 17 impossible cases, and a complete collapse of my understanding of medical science, I could no longer function in an operating room. How do you administer anesthesia when some patients don't respond to cardiac arresting medications? How do you assist in surgery when the pathology you're treating might not actually exist? How do you provide post-operative care when recovery patterns violate everything you've learned about human healing? Most disturbing of all, how do you trust your own skills and judgment when you've witnessed colleagues performing at levels beyond human capability with no memory of their enhanced abilities? I submitted my resignation on November 8, 2024. Dr. Foster accepted it with understanding, but asked me to consider the implications of walking away from cases that might represent breakthrough medical phenomena. What if these patients represent evolution in human physiology? She asked. What if we're witnessing the emergence of enhanced human healing capabilities? Shouldn't we be studying this rather than running from it? But I couldn't shake the feeling that we weren't witnessing medical evolution. We were encountering something that used the appearance of medical healing to mask purposes we couldn't understand. The patients were real. Their conditions were documented. The surgeries happened exactly as recorded. The outcomes were medically impossible but undeniably successful. Yet something about the entire pattern felt fundamentally wrong, as if we were participants in procedures designed to look like medical treatment while serving some other purpose entirely. In my final week at Riverside, I learned that similar cases were being reported at other medical centers across Ohio. Cleveland Clinic had documented 12 cases. University Hospital in Cincinnati had 7. Ohio State Medical Center had 23. All showing the same pattern: impossible surgical outcomes, enhanced physician capabilities, and mysterious changes to preoperative imaging. All involving patients who should have been critically ill but experienced perfect recoveries. The cases are spreading, not just geographically, but in frequency. What started as isolated medical anomalies have become a pattern of systematically impossible healthcare outcomes. I now work as a medical equipment sales representative, traveling between hospitals across the Midwest. It's honest work that lets me sleep at night, though I still scan medical journals and online forums for reports of unusual surgical cases. They're appearing everywhere now. Cardiac surgeries in Detroit where hearts won't stop beating. Orthopedic procedures in Chicago where bones heal during the operation. Neurosurgeries in Milwaukee where brain tissue regenerates in real time. Each case identical in pattern to what I witnessed at Riverside. Perfect outcomes achieved through impossible means. Enhanced surgical capabilities in physicians who can't explain their temporary superhuman skills. Preoperative imaging that changed after successful treatment. I wonder how many other medical professionals have encountered these cases and chosen to remain silent. How many have attributed the impossible outcomes to luck, equipment malfunction, or misremembered observations, rather than documenting what they've actually witnessed? How many patients walking around today are living with perfect health achieved through medically impossible procedures, unaware that their recovery violated every principle of human physiology and surgical science? The cases I documented at Riverside Medical Center remain in the hospital's files, available for any researcher brave enough to investigate that challenge the foundations of medical science. But I suspect most physicians would rather focus on cases they can understand and explain within the boundaries of established medical knowledge. I don't blame them. There's comfort in treating conditions you recognize, with procedures you understand, achieving outcomes that match your medical treatment. There's safety in staying within the boundaries of what's scientifically